No, it worked. It did.
Test 1, 2, 3. Yeah, it's okay. Barabar?
All right, we're going to get started. If you wouldn't mind taking your seats, please. आवारस अशरा मुबारका निवाज माँ मौलाए मौलाना अली ना कलाम मुबारक मासी बरकत लईने बयान फरमाया छे इमाम मौलाना अली फरमावे छे तलब तो तवाज़ो व वजदहु फी क़बूल अल हक़ I sought humility and I found it in the acceptance of truth. The search for the ultimate truth is exactly the process and the aim of science. To speak to us on incorporating evidence-based medicine into our practice, SBMAA proudly presents Dr. Munira bin Basrai and Dr. Burhan Mohammedali. Dr. Basrai joined the NIH in 1998 after completing her training at Johns Hopkins University. She's a senior scientist in the genetics branch of the National Cancer Institute, where she serves on the Cancer Advisory Board. Dr. Mohammedali completed his training in cardiology at the University of Illinois with a specialty in advanced heart failure. He serves as the Director of Clinical Research at Sharp Health Services in San Diego, where he runs multiple clinical trials and mentors trainees on the heart transplant service at UCSD. Dr. Basrai and Dr. Mohammedali, thank you and welcome.
Bismillahirrahmanirrahim. Thank you to the organizers for giving me this opportunity to talk about our work. As Amir said, I've been at NIH and my lab basically works on basic research mechanisms, but today what I hope to show you is how evidence-based medicine can lead to detecting vulnerabilities in cancers. So the purpose of this talk, the take-home message that I want you to get is that translational research will allow us to cross the valley of death, right? Cancer is definitely a valley of death in most cases, and we hope that translational research will allow us to cross that valley efficiently. And this is, in the talk today, what I want to present to you is how learning from every patient will allow us to bridge the translational gap in small cell lung cancer. So I'm going to use small cell lung cancer basic research to illustrate to you how benchside research can be translated into the bedside. So the outline of my talk is to describe to you briefly the statistics of cancer in the US, to highlight for you a very important feature for most cancers, which is chromosomal instability, which is what my lab studies. Outline for you a few statistics and incidences and aggressiveness of small cell lung cancer. And then if I have time, I'll highlight for you our findings from my lab, how we can apply the benchside research for better prognosis. So in terms of the cancer statistics, nearly 1 million cases of cancers are estimated to happen in the US every year, and this is from 2022. And roughly 1/3 of these patients will succumb to death. So it's clearly one of the second most important causes of death in the US, besides cardiac, which Dr. Burhan Bhai will be talking about. So an important feature of most cancers is chromosomal instability. And shown here is an array of chromosomes painted with different colors. And as you can see, these colors are fairly uniform. But if you take a cancer cell, you see heavy incidence of translocations where a pink chromosome is fused to a green one, and so on and so forth. So this is a very characteristic feature of cancer. So for example, if you do a karyotype, you count the number of chromosomes in a normal human cell depicted over here, you will find that you have 2 copies of every chromosome. But if you look at a colorectal cancer cell line, you will have 1 or 2 losses and gains of many chromosomes. Now, a distinctive feature that contributes to this is chromosome segregation errors. So chromosomes, when they duplicate, they go to the opposite poles of the cell, and these are the chromosomes aligned on the metaphase plate. And on the next slide, I will show you how errors in aligning these chromosomes or taking them to the daughter cells can contribute to this CIN phenotype. So for example, over here in a normal cell, all the chromosomes are aligned in the metaphase plate, and when the chromosomes segregate, an equal complement goes to the opposite poles. However, when errors in chromosome segregation can happen, you might find lagging chromosomes that fail to keep up with the other chromosomes, and this contributes to chromosomal instability. So I don't know if this movie is going to play, but here is a movie of chromosome segregating, and on the right, and you will see that in the movie on the left, the chromosome will just suddenly not keep up, and it will be in the center of the plane. And let's see if I can play this one. This one was my pretty one. Well, I guess I didn't get popcorn for you, so you can't see a movie today. But so anyway, lagging chromosomes are a very distinct feature of many, many cancers. And so today what I will talk to you is about research done in collaboration with my lab, which we just got very recently involved. But this research is done by Dr. Anish Thomas. He is originally from India, from where we are, and he's a Lasker scholar, and he is really the world-renowned scientist in terms of small cell lung cancer. And so what Anish has done is leveraged the awesome power of clinical trials that NIH can do to investigate the vulnerabilities of small cell lung cancer. So depicted here is the NIH Clinical Center, which carries out clinical trials for many things. And I encourage anybody in the audience, if you are interested in doing anything collaboratively with NIH in terms of clinical trials, treatment, training, opportunities, please reach out to me. I'd love to help Muminin get to the next stages of the career and achieve what I have been able to achieve with Mullah's Dua. So in terms of Anish's work, he recently published this article in which he showed that when you target a particular pathway in small cell lung cancers, these patients, they respond and the median survival goes up. So for example, in small cell lung cancers, you have this very high incidence of chromosomal instability that I just described to you. Look at over here, you see numerous copies of these yellow and green chromosomes. And my lab routinely does this, where we map the number of human chromosomes. So what Anish used was, he used this chromosomal instability as a vulnerability. And the incidence of small cell lung cancer is about 30,000 cases. But most importantly, the 5-year survival rate of these cancers is less than 1%. It's a very, very recalcitrant cancers. So the treatment that is given for these cancers usually is Topo2 inhibitors. And the patients will usually respond, and this tumor mass will shrink. But very rapidly, within days, the cancer will reoccur. So within a few days, the cancer relapses. You see more cancerous masses. And these cancers, most importantly, they progress, and they are very difficult to treat. They become chemo-resistant. So this is one of the major causes where the survival rate of these cancers is less than 2%. Now, why am I standing here talking about this? Because for most tumors, when the patients don't die that rapidly, you're able to recover clinical samples and perform studies. But small cell lung cancer is a very deadly cancer because by the time the patient gets diagnosed, it has already metastasized, and the red rate is so high that you can very rarely recover samples. Being at the NIH and having a very large cohort of patients from all over the world, Anish was able to leverage his bench-side findings into the clinic. So that gave him a unique opportunity. And what Anish found was that these cancers are very difficult because they are resistant to chemotherapy. The clinical stuff that my lab does in terms of mapping, you know, the genome, the methylome, the characteristic features are just not present in small cell lung cancer because these patient tumors are just not available. So these tumor samples are not available. So how do you treat such a cancer where the metastasis is very rapid, you don't have patient samples, right? So a clue for Anish came from these studies where most of the studies that have been done with small cell lung cancer have been done in cell line models. And cell line models is not an ideal model to study cancer. So we really have to go to the patient samples. So the goal of Anish's study was, right now, one size fits all. You use the same treatment to treat every patient, and it really doesn't fit because these patients relapse. So what Anish's research has done, and I'll show you at the end, and this is my take-home message, if you don't get anything, he has identified these small cell lung cancers that have high replication stress. And he has targeted this high replication stress, combined it with DNA targeting agents, and allowed them to treat cancer. So depending on the underlying cause of these cancers, you can target patient therapy. And I'll just show you a small example of how he did it. So the goal was to leverage the clinical observations and genomics to advance these therapies and to use deep learning approaches to apply these findings. So one of the other features about cancers is that when the cells, they replicate, there's replication stress. And we have to divide our DNA, so we have to go through replication stress. So mostly all cancers have this signature of replicative stress. Now, why do cancers survive? I mean, they are stressed, so they should die, right? But one of the things that happens when you're going through replication stress is you activate this pathway called ATR, which is not important for you to know, checkpoint pathway. So the moment the cell recognizes there's replication stress, this pathway goes up. When this pathway goes up, the cells stop and say, well, something is wrong, let me rectify it. And when the cell tries to rectify it, it gives time to the cell to replicate their DNA to fix the damage. And as a result, the cells proliferate. So this is the underlying cause for high proliferation of cancers with replicative stress. So the common sense strategy is that if you target the ATR pathway and you inhibit it, you will inhibit the proliferation. So that's exactly what Anish wanted to do. So he took the patient samples and the tumor samples, and he found out whether these patients had replicative stress. And indeed, he found that the markers of replication stress, the few genes that we study, were upregulated in this cancer. So this was an ideal situation. He said, these genes are upregulated, so how do I inhibit the ATR? If I inhibit the ATR, I will prevent the proliferation, I will treat the cancer, and he was highly successful. So what he did was, he used, there are several ATR inhibitors in clinical trials, and they are used for many, many different cancers. So for the purpose of this talk, let's forget about the biological name, but this is the compound he used. So the patients that were given Topo2 inhibitors that relapsed and the cancers were not able to be treated, Anish combined the Topo2 inhibitor with the ATR, and the results were amazing. This is not with SCLC, this is in cancers, that have replicative stress. And what he finds is that this trial was done for 2.5 years. The patients were given Topo2 along with the ATR inhibitor at 21 days intervals. And the results are very striking, as shown here. Nearly half of the patients, the tumor volume regressed. It was very significantly regressed. And shown here is the tumor from this patient before treatment and after 3 months of treatment. And even after 5 years, the patient is alive. So this strategy clearly worked in the clinical trials. Combining an ATR inhibitor with Topo2 worked for him. So he next took this study to the small cell lung cancer model, and amazingly, in this also several patients were enrolled. Anish basically has 13 clinical trials going on at NIH. And what you find here very striking is that 68% of the patients responded with the tumor volume regressing, and you found response in at least 9 out of the 25 patients. So I hope so far you've been convinced that the bench-side research that was done in Anish's lab in terms of identifying replication stress as a vulnerability allowed him to take these into the clinical trials. So these studies are being done by Anish, and several of these patients are being enrolled. The studies are progressing, and we hope that at one point the FDA can approve it. So the take-home message from this is that one size does not fit all. The treatment that you approach for cancer is based on the underlying cause of cancer. And what Anish has been able to do is use this replication stress as a strategy to target these cancers that have a high replication stress. And then, of course, if you have germline mutations, you have another option. So in summary, what we want to do is use patient-derived samples to understand and to cross this valley of death. So I don't know how much time we have, but I'll wrap up in 2 minutes what my lab does in this. So I'm basically an yeast geneticist. I trained at Johns Hopkins on budding yeast as a model system, because roughly 90% of the genes in budding yeast are conserved in human cells. And then a few years back, NIH recommended that I move my studies to human cells and mouse models. So we've done that, and we've been quite happy and very successful with Molas Dua. So we study determinants of chromosomal instability. And one of the proteins that my lab has extensively studied, and we published many papers on this, is this protein called CENP-A. So for the purpose of the talk, I only want you to remember that CENP-A goes to the constriction of this chromosome, and this is absolutely essential to prevent sin. So my lab recently published 2 studies in which we showed that when you don't restrict CENP-A there, and it goes all over the chromosome, you see chromosomal instability. And we've done this in mouse models, human cells, budding yeast, so on and so forth. So these studies were very gratifying for us, because we really had worked on budding yeast for many years, and we were able to apply it into the human cancer model. Now, why are these studies important? Because overexpression of CENP-A has been reported in many, many cancers. So that was published for colorectal cancer, and the list continues to grow from triple-negative breast cancers to colorectal cancers. This protein that my lab studies is heavily overexpressed, and we have shown that it gets mislocalized. So we decided, Anish approached me about a year back when my paper came out and said, hey, Munira, I think the protein you are studying might have to contribute to the aggressiveness and the chemo resistance of small cell lung cancer. So we started a collaboration, and the studies have been very encouraging, but let me show you some published data that just came out last week. So this is the protein I study, CENP-A. So when you take a normal cell, the protein is nicely evenly distributed throughout the nucleus. But when you take neoplastic or invasive cancer, this protein that I study, the nuclear localization is heavily disrupted on tissues. And the list of these cancers is ever growing. I mean, there are at least 16 cancers where this is done. So what this study said was CENP-A localization pattern can be used as a biomarker for predicting radiation resistance, and the results are quite striking. So it's a very simple test. We have many tissues at the NIH. We can do CENP-A staining. And most importantly, what my lab has recently discovered, that CENP-A is overexpressed in small cell lung cancers. And we've tried to overexpress it, and so we are hoping whether CENP-A can be used as a prognostic and diagnostic marker for small cell lung cancer. So in summary, I hope that translational research will allow us to cross the valley of death, and one patient at a time, we will be able to fill in this gap. And with that, I thank my lab members, a very dedicated team, and Mullah for his dua for my success. Thank you.
Do you have the other slide? You guys can all watch me? No. Look at my moves. right, so that was, by the way, that was great. Thank you, Munira, for that presentation. And again, translational research is very important. And as we will see, everything we do as clinicians would not be possible if we didn't have translational research. So what I'm going to do next is I'm going to switch some gears and move on to the next phase, which is we're going to mainly talk about clinical trials. And when Amir Bhai initially approached me about clinical trials, and he's like, hey, he called me and he's like, hey, Burhan, we would like you to talk about a topic at the conference. I was like, yes, perfect. I'm like, which part of heart failure should I talk about? And he's like, oh, no, we're going to talk about clinical trials. And I'm like, really? I'm like, I mean, you guys are giving me the most boring part. Most people fall asleep by the time you start thinking about statistics and everything. So with that, I was like, come on, give me something more interesting. And he's like, no, Burhan, you have to do clinical trials. And I'm like, okay, fine. We'll do clinical trials. So with that, let's talk a little bit about how we interpret clinical trials. But first of all, we're going to talk about a basic scientific paper. And again, this is most of you guys are very familiar with this. We have a title section, an abstract section. There's introduction, methodology. This is very common. So this is dry, vanilla stuff, right? So you guys are all very familiar with this. But there's a couple key questions that need to be answered that oftentimes, we are not fully paying attention to. And especially in our busy practices, we don't have time to critically read all these papers. And a lot of times these drug reps come to you and say, hey, Dr. X, this drug is amazing, blah, blah, blah. Just start using this. It's great. This shows this number, and just throw some numbers at you. And, like, oh, wow, it's great. But, I always tell myself, I'm like, whenever somebody comes to me and says, hey, my drug is great, I say, show me the data. Show me the data. Always show me the data. And we'll talk about this in a little bit. But here's the key things, right? A good paper is written in plain English. If there's jargon there, you should always raise a red flag. Why there's so much jargon? Because if it is straightforward, it should be straightforward, right? There shouldn't be some complicated words and this and that or whatever, right? Highly reputable journal, New England Journal of Medicine, can have bad papers. Just because something is published in New England Journal of Medicine or the Lancet or whatever have we, it doesn't mean that it's automatically the best paper there is. It automatically is the best evidence. Always ask questions. You are not a statistician. Do not let the statistics intimidate you in any way or form. Again, let the treatment talk for itself. If it's good, they don't need complicated statistics to prove it that it's good. All right? And then, the results have to always make sense. So with these caveats in your mind, always think of papers in that way. All right? So when we look at, a new therapy, whatever, some new drug came out, some key questions, with that therapy is it valid? Was the science good? Was it conducted well? Was it well researched? Is it important? Is it going to change management? If you are dealing with obese patients who are 200 pounds over, 100 pounds over, and there's a drug rep comes and sells you a drug which is guaranteed to lower 5 pounds, well, that's great, and it works for lowering 5 pounds, but that's not relevant, right? That's not your population. It's not going to be applicable to you because, you're trying to make your patient lose 100 pounds, and then here, just rep is saying, hey, this is a great drug, guaranteed weight loss. When you look at the numbers, 5 pounds. Well, that's not good enough, right? So, all right. So, let's talk about a couple of things. And I know this is kind of stuff that puts most people to sleep, right? I mean, this cartoon here represents how I feel when I see these things. Like, man, not again. I don't deal with this stuff, right? So, absolute risk reduction and relative risk reduction, number needed to treat, and number needed to harm, and all this other stuff, and really, I mean, I put this here just as a primer. I don't want to go through this. The object of this talk today is not to go through statistics. I don't like statistics. I kind of find them boring. It's just too many numbers. But these are important things that we want to know about, and this is again basic stuff. These are the three things that most of you guys already know, but I think it should be a good practice to just start doing. It's very simple to do. You can do it very quickly by yourself, without the drug rep spinning it to you in one way or another. Absolute risk reduction, very easy. You guys already know this. Control group minus treatment group, very easy to calculate. The events in a control group versus events in a treatment group. Relative risk reduction, again, is just a ratio. So essentially what you've done, you've taken the absolute risk reduction and you divided by the control group, the incidence of whatever, so I said drug X lowers blood pressure by by 10 millimeters of mercury in group 1 versus, versus the other group where there was 1 millimeter difference, and then, you divide it by 1 millimeter and whatever. But you guys already know this, so I don't want to kind of spend too much time doing this. We'll use some practical applications of this. And then number needed to treat, again, which is 1 over absolute risk reduction over here. And then number needed to harm, because sometimes, we're studying a drug, and instead of causing benefit, it actually causes harm. So, instead of absolute risk reduction, we come up with absolute risk increase, which means that in some patients, a drug may actually cause harm instead of benefit. So still similar calculations, so you try to calculate the absolute risk reduction, you do 1 over absolute risk reduction, which is number needed to treat. If this drug is negative and it causes harm, then you'll find number needed to harm. Same kind of way, and these are very easy things to do, and you should be able to do. Now, this is one of the bane of my existence, subgroup analysis, right? They all come and always try to sell a drug to you based on subgroup analysis. So whenever a drug comes to you and says, the subgroup analysis showed X, Y, and Z, I will always be like, where's the data? Show me the data, right? And what does subgroup actually tells you? One thing is that you always have to make sure that the subgroup analysis was something they thought of beforehand. It's not something that just happened to find out in their research. And we will talk about this when we actually talk about a paper, But some of the caveats of subgroup analysis that always take it with a grain of salt, and we will go into details of this. So with that, this is the end of statistics portion. All right, everybody can wake up now. Everybody wake up. We're done with statistics. Again, I want to keep it brief. I don't want to lose people. People start thinking about Timbuktu, taking a nap. People start dreaming and stuff. We don't want that. We want full attention right now. So let's talk about a paper. So I picked this paper. This is an old trial from 1999. It's a Rails trial. It's a heart failure trial. And being a heart failure cardiologist, this is a very, very pivotal trial to us. So this is a trial that talks about the effect of using spironolactone on morbidity and mortality in patients with severe congestive heart failure. So again, the title is very self-descriptive. You can read the abstract and all that. It's a pretty straightforward trial. So let's kind of analyze it. What was the clinical question this trial was asking? It's asking, in patients with congestive heart failure with low ejection fraction, will addition of spironolactone reduce mortality? That was their main question. That was their primary endpoint. What is the mortality? Is this drug going to decrease mortality in this patient population? There is a null hypothesis, which yourselves. I don't want to spend too much time with that, but the primary endpoint is all-cause mortality. Look at the secondary endpoints. These are predefined secondary endpoints, which looks at cardiovascular mortality, CV hospitalization, or the combined endpoint of the mortality or hospitalization. So, again, looks at that. So asking it some key questions. Does it change how you're going to die? Is this going to influence cardiovascular death? Is it going to influence heart failure hospitalization? So there's some pretty heavy endpoints. Not like, is it going to make you feel better, or is it going to reduce your blood pressure by 2 points or something like that? So it's looking at some real hard endpoints, right? So that always tells me that, okay, that's a good trial. It's looking at some pretty key endpoints. Now what's the design? Did they enroll only 10 patients and come up with this information? No, well, they enrolled about 1,600 patients. So it's a pretty good sized trial. It's a multi-center trial in 15 different countries, 195 centers. It kind of tells me that there's some weight to this trial because it's been studied not just in one place, in different places, in different countries, right? So it kind of gives me a little idea that, okay, we're dealing with something good. It had a long follow-up time, in which we see it's studied over a few years, mean follow-up time of 2 years. And again, the primary outcome is all-cause mortality, not some surrogate endpoint here and there. This is a population that was enrolled. And again, I don't want to spend too much time in this, but here, we have patients with, this was the inclusion criteria, mostly enrolling class 3, NYHA class 3 and class 4 patients, on good treatment and having an EF of less than 35%. And the exclusion criteria is over there too. So let's look at table 1 in here. And what I like about this is that they didn't enroll only young patients in this trial. What is the average group? I'm looking at this table 1. It gives me an idea, just a flavor of what we're dealing with in terms of the characteristic of the population that was enrolled in this trial. We have patients age 65 and above on average. Again, that kind of follows my population, because if they're enrolling 18-year-olds and 20-year-olds and 30-year-olds, I'm like, well, most of my patients are old. right? So maybe it's not applicable. So it says maybe it's applicable to my patients, you know. And then let's look at some of the things, you know, in terms of heart failure, how sick were these patients? So I see that they're mostly enrolled in class 2, and mostly in class 3 and class 4 patients. So sicker patients, not the healthier class 1 and class 2 patients. That tells me that this, again, you know, they're looking for some real detail here, you know. And then looking just overall, you know, what was the ejection fraction of patients admitted in this trial? Average ejection fraction was 25%. So it tells you that there are some real sick heart failure patients, not your, you know, your 50% EF, 45% EF, you know. So we're looking at some real sick patients. So I like this when I look at this. I say this is a trial where they actually thought about it. They want to enroll some sick patients. They really want to show that there is a difference here, you know. So now this is again the result of the trial. You see, this is the Kaplan-Meier curve. You know, this trial was stopped early because the Data Safety Monitoring Board said this is again this is a life-changing event. At this point in time, you cannot continue the trial because there is just so much data favoring the drug that at this point in time, if you continue giving the placebo group placebo, it's unethical. So the Data Monitoring Safety Board actually stopped this trial early and said, no, you have to stop because there's so much benefit with this drug that you actually have to start giving the placebo patients this drug as well. You know, so again, that's a big deal, right? And it's led to guideline changes. What about the other outcomes? You know, we talked about the mortality already. You know, the secondary outcomes, they looked at CV mortality, CV hospitalization, CV mortality or hospitalization. You can kind of see them. They're all statistically very significant. So all pan positive, everything, all the endpoints they were looking at, the primary endpoints, the secondary endpoint, everything they're looking at showed major difference compared to placebo. You know, and then they also had some adverse events here. So there's gynecomastia in this trial. It was noted 10% patients developed that versus 1% in the placebo group. There was elevated potassium that was also noted, but again, not a big deal. But these are also some safety endpoints that are looked at as well. You know, so when I look at this trial, I'm like, okay, well, this is a big deal. This is a very good trial. It shows a lot of positive effects. You know, and the Data Safety Monitoring Board also looked at this. Now, remember the calculations we did earlier? We can do that calculation for this trial too. In this paper, they didn't give us this information, but it's not very hard to do. You know, when I look at this outcome over here, it's very simple. I just say, you know, there are 386 patients in the placebo group. You know, in terms of mortality, there was 284 patients in the spironolactone group. I know how many patients were enrolled. I know there's 841 patients in the placebo group, 822 patients in the spironolactone group. I can calculate these numbers myself very quickly. Right? When I have these numbers, I can very quickly calculate absolute risk reduction. Again, none of this was given in the trial, but I don't need them to give me. I can just figure this out. It's very simple stuff. It's basic math, right? I can calculate the absolute risk reduction. I can calculate the relative risk reduction, and I can very quickly, easily calculate the number needed to treat, which comes to 9. You know, so you can very quickly do this, you know, in your head when you start getting these trials. Very quickly, just kind of get a rough idea of how good this drug is. You know, despite all the other stuff, you can also kind of look at this stuff too. Now, if you got a number needed to treat of 100, then you're like, maybe I don't know if this is really worth it. You know, but kind of gives you an idea, adds secondary validity to what the trial is trying to project. Okay, so with this information, this spironolactone is now a cornerstone of heart failure management. You know, so when you're treating patients with congestive heart failure, you are one of the medications that you should put them on as part of guideline-directed medical management is that they have to be on spironolactone, you know, or eprenone or whatever, some drug in that class. So now let's move on to the next paper. So I want to shift gears right now. This is a trial from last year. This is the FIGARO trial where they're studying finerenone. Finerenone is a non-steroidal analog that works similar to spironolactone. All right, so and we're going to go into mechanism of action again. A New England Journal trial, you know. So again, you know, very high impact journal. So it tells you that again, this is New England Journal, you know, critical. They go through review process and everything, you know. So you know, again, remember, just because the New England Journal doesn't mean it's a really good trial, but it just kind of gives some validity to that. But let's look at how this molecule works, you know. So it is the same kind of concept. It blocks mineralocorticoid overactivation, you know, which contributes to inflammation and fibrosis. And this drug was initially studied in the kidney population, the CKD population, where they found out that it had a cardiovascular mortality benefit. There was a subgroup analysis which showed that there may be a cardiovascular benefit. Now remember, subgroup analysis have to always be taken with a grain of salt, because if subgroup analysis says that there is something, you actually have to follow up with another trial looking at that particular something with the a priori hypothesis, saying that we're going to study this drug for this result and see if it actually shows that. So, okay, so let's, so over here we see that in the Fidelio trial, which is a trial that predated the FIGARO trial, they showed finerenone slowed down CKD progression and improved cardiovascular outcomes in patients with CKD and type 2 diabetes. All right, so this showed that, but they also showed there's cardiovascular benefits. So now the FIGARO trial was done to show that, to prove that the cardiovascular benefit that they saw in the previous trial is a true effect and not just something they saw by chance. So what they found, so we're going to go into this trial. The hypothesis of this trial here is that finerenone reduces cardiovascular morbidity and mortality and expands the evidence base to broaden the use in just not only CKD patients, but also for cardiovascular benefit. So let's look at how this trial worked. What is the inclusion criteria? Again, big trial, right? Big trial. When you look at it, they have 7,000 patients randomized. 7,000 patients. So very big trial. Inclusion criteria: 18 years of age, EGFR greater than 25, and other stuff right here. Key exclusion criteria: patients with congestive heart failure, NYHA class 2 to 4 are excluded. The symptomatic patients who are NYHA class 2 to 4 were excluded for the trial. And then again, their primary endpoint was CV death, non-fatal MI, non-fatal stroke, or heart failure hospitalization. All right, so this is the combined endpoint. Remember, the earlier trial we saw was individual endpoints. This is a combined endpoint. So it kind of just tells me that, okay, when they're combining endpoints, I always have to take it with a grain of salt. And why are they combining endpoints? If they're combining endpoints, maybe is the drug not powerful enough to just just give you CV mortality by itself, that you have to combine stuff. So I always, whenever you have combined endpoints, always, look at it again and say why. Why? The why has to be answered. All right, so what did this trial show? Again, a statistically significant trial which showed that finerenone reduces the risk of primary cardiovascular outcomes. Again, these are the 4 outcomes we talked about earlier, by 13% compared to placebo. This is the Kaplan-Meier curve. You get statistical analysis. P-value is less than 0.05, 0.026. And found out that it was a good drug. So now. So based on this, again, and then they did the subgroup analysis. So now the subgroup analysis, subgroup analysis is important because it tells you that if a drug is statistically significant for a composite endpoint, which one of the 4 is actually driving this? All right, and this is where the forest plot comes in very, very handy. So here is a primary outcome, which is all 4 of these combined. And out of these 4, which one of this is actually causing this to be statistically significant? And we can see the non-fatal stroke, nothing here. It crosses 1. So that means it's not statistically significant. We see non-fatal MI, not statistically significant. CV death, not statistically significant. Heart failure hospitalization, very statistically significant, right? So big time change in terms of heart failure hospitalization, reduction in heart failure hospitalization. So based on this, we see that this primary outcome is mostly driven by the heart failure hospitalization, all right, which is great because now they see that maybe this drug, can be good for heart failure patients, all right? So, but here's my problem. Remember the key exclusion criteria? NYHA class 2 to 4 were excluded. They were not included in this trial, right? So as part of the trial's enrollment criteria, if you had congestive heart failure, symptomatic congestive heart failure, and you had NYHA class 2 to class 4 symptoms, you could not be in the trial. So only patients who are enrolled who had heart failure were the patients who were actually well-controlled, were asymptomatic heart failure patients. So now the drug reps are all over me. They're coming in. Dr. Mohammedali, we have this amazing new drug, which can be used for your heart failure patients, and it doesn't have side effects. It doesn't have gynecomastia. It doesn't have hyperkalemia. You should consider this. And I ask him, I'm like, okay. So the drug rep comes on. I'm like, why would I use your drug? Because I already have spironolactone, which has a proven mortality benefit. You tell me your drug is a heart failure hospitalization reduction, but you haven't told me you have a mortality benefit. And then I say, okay, can you give me the trial where you get this information from? So they give me the trial, And they're all over how it reduces heart failure hospitalization, right? It's like heart failure hospitalization, reduction. And I'm like, then I ask him, I'm like, can I substitute this for aldactyl? And they're like, oh, why not? It's the same molecule. You know, this one is steroidal, you know, it has more side effects. This one is non-steroidal, there's less side effects. And I'm like, okay, well, I'm like, so where is your data shows me that it's good for heart failure patients? Well, they show me this data right here. They show me this data and say, look, how your heart failure patients are doing so well with this medication. And I asked him, I'm like, can I see the whole trial? You know, so they sent me a copy of the whole trial, and I read it. And this was perfect time because this is when Amirbhai had reached out to me and said, hey, can you talk about a trial and talk about drug wraps and everything? And I was like, this is perfect. You know, so I'm like, the drug had come to me, and I was like, I don't see your drug being good for heart failure patients because you're asking me to take a drug that is known to have a CV, cardiovascular mortality benefit outcome, and replace them with a drug that may have a heart failure benefit outcome if you're asymptomatic. You know, so I'm like, I cannot do that, right? So then they're like, oh, we have to get you our medical liaison, our pharmacist to come and talk to you. I'm like, oh, sure. The next time they come back and they bring them pharmacist liaison, whatever, and they said, why don't you use our drug? And I'm like, I can't use your drug because seriously, you know, I have some major concerns about your drug because one, you were enrolling patients they did not have symptomatic heart failure, and I treat symptomatic heart failure patients. And then they're like, yes, Dr. Mohammedali, you're right. You know, we cannot ask you to use this in symptomatic heart failure patients because this drug was excluded from being used in symptomatic heart failure patients. Now, it doesn't mean that this drug is not good for heart failure patients. It just means that they need to do another study, enroll all the heart failure patients, class 1 to class 4, and give it to them. Half of them should get spironolactone, half of them should get this one, and then they can compare and show that how this drug is compared to spironolactone. You know, but right now, if they come and tell me that, hey, substitute your drug for this, I'm like, can't do that, sorry. You know, and I think they've stopped coming now. You know, they stopped coming. They're like, other cardiologists do that. I'm like, well, that's up to them. You know, I'm like, I can't do that. You know, so with that, move on here. So, you know, this is a summary of the trial. You know, and you guys can again read it, but again, it says the same kind of thing that we just talked about. You know, that it will reduce cardiovascular death and mortality by 13%. Remember, this is a composite endpoint, which was mostly driven by heart failure hospitalizations, you know, and a favorable trend towards, again, this is a secondary outcome they're looking at in kidney patients. So, with that, we're critically trying to interpret this data. So, would you use finerenone in heart failure patients? Asymptomatic heart failure patients. Maybe you can make an argument for that, right? So. There has to be a head-to-head. Yes. Without the head-to-head trial, exactly. And you know, so again, you know, so I cannot. So when they come and say that, hey, you have to replace, you can try to replace this, and I was like, I don't have that data yet. You have to give me more data. You have to do more trials. And again, the company is doing more trials, you know, more geared towards heart failure patients, cardiovascular population. When that data comes in, I'm not saying this drug is not good. I'm just saying I don't have evidence to say your drug is as good as what I already have, which is good. You know, does it have cardiovascular benefit, right? So you can say, yes, this drug has cardiovascular benefit, but where was the cardiovascular benefit? Remember those four things that we saw? It only had cardiovascular benefit in terms of reducing heart failure hospitalization, right? It was mostly driven by that. So maybe they need a larger study, you know, with patients with significant cardiovascular morbidity to see if it actually works equally well. You know, would I be able to substitute spironolactone for finerenone? You know, I don't have that data to say that I can. You know, so in my practice I don't do that. So the drug reps are kind of, they came like 4 times, 5 times, now they've given up. They don't come anymore because again, same kind of thing. I tell them I cannot do that. You know, so with that, you know, what have we learned today? You know, so one thing is that, you know, what Munira talked about is that there is a translational part of research, which again brings us this medications, right? So without that, what Munira and other scientists do, we're not going to have these drugs. And when these drugs are finally gets to a point where a drug is developed, it can actually be studied in a clinical trial. And then it can be a slam dunk clinical trial like the Rails trial that we saw. Again, huge benefits, and then it can be not a slam dunk like the FIGARO trial we saw that doesn't have that profound cardiovascular benefits. Great kidney benefits though. So great kidney drug can be used in kidney population. I'm sure it does wonders, but without further data, I cannot convince myself that I can actually use this in this particular population. But the reason why I'm doing that is because I looked at the trial, right? I looked at the trial, I read the trial, and I said, what you're saying is great, and it's correct. It's like great heart failure reduction, great benefit in heart failure patients, but I'm like, not for my population, right? So in conclusion, what we're going to talk about is that we have to always be critical thinkers. You have to be critical thinkers. You have to always ask the question, say, if this drug trying to sell this idea, are there any holes in what they're trying to tell me, right? Are there any holes? Look for those holes. Try to read, if possible, try to read the trial. Look at the inclusion-exclusion criteria, because if I had not looked at the exclusion criteria, it was buried in there. Heart failure patients were excluded. So here a drug rep is coming in trying to tell me that, hey, use this for heart failure patients, but heart failure patients are excluded from the trial. I have a problem with that. And again, be very careful with subgroup analysis, right? So subgroups don't prove anything. If there's subgroup analysis, like we saw in that one, the heart failure patient, I told the drug company, I'm like, you guys need to just have a dedicated heart failure trial where you enroll all heart failure patients. And they say, oh yeah, we're actually already doing that. I'm like, great. So when your trial comes out, your next trial comes out, we'll have more data. I think, Amirba, you are enrolling, right, in this trial? Heart failure, yeah, perfect. So they're like, we're already doing that. I'm like, perfect. I will wait, until you have that data, and you can prove it to me that I actually can substitute this medication for your medication. When that data comes out, we will be up there, and we'll be ready to invest in this drug. But until then, we got to wait. We got to wait for more data. Okay, so don't trust drug reps. That's a key take home, because they're trying to sell something. If they can sell it to you, if they can be your best friend, if they went to the same high school as you did, whatever, sometimes they come up with the stories. I don't even know how they come up with it. It's like, hey, I was over here with you. I probably was in the same school as you, and I was like, okay, great, but tell me about your drug. So take everything, with a grain of salt. All right. And remember, you can always do your own quick calculations, the absolute risk reductions, the number needed to treat. This calculation is straightforward, very simple, it doesn't need complicated math. They're not always provided. Some trials will give them to you right away, but other trials you actually have to figure it out yourself. It's very quick exercise, just always kind of get in this mode of doing these things. And with that, I'd like to open up for questions, but before we do that, I do always, our shukur wajib che, Maulana gonu motu ehsan che, that we're actually here. We're gathering together here today. We're trying to learn. We're trying to network. We're trying to meet each other, and trying to again progress our field and progress our name. So with that, I dua kare Khuda Taala Maulana Umar Sharif Kamal and Daraz and Daraz kare. Amin. Thank you.
Thank you both. If anybody has any questions, they can come up here to the front,
or here,
or on that side. I have a question for Dr. Mohammedali, if I may.
Yes.
You mentioned number needed to treat, which I think is a statistic which is not often reported, and it is extremely, extremely important. There's also a number needed to harm that we can look at for risks of medications. Is there a single statistic that encompasses both of those numbers? And if so, what is it and how is it calculated?
Yeah, so the two are opposite in the fact that, if you're looking for an effect of a drug on a certain patient population, and if there's a benefit, when you subtract, you see that let's say, for example, mortality, that drug X has 25% mortality, and drug Y has 35% mortality. So when you're doing the absolute risk reduction, you will do 35 minus 25, right? So that's going to give you 10. and it's going to be 1/10 is going to be, you know, your number needed, that's your number needed to treat will be 10. So, but if for number needed to harm, you know, let's say that you're studying drug X, which you expected to have lower mortality, but now it has 35% mortality, and drug Y, which is placebo, has 25% mortality. So now those numbers are reversed. So you would actually subtract it the other way around, because otherwise if you do the standard, you know, control minus study group, you'll have a negative number. You know, so that's called absolute risk increase rather than absolute risk reduction. You know, and then you'd still again kind of do it the same way. So you kind of have to do those separately based on what the outcome of the study is.
Well, I ask because, you know, one of the major things in our field is anticoagulation. And so we're always trying to balance efficacy of anticoagulation with safety of anticoagulation, and I was looking to see if there was a single statistic that you use that looks at overall clinical efficacy, balancing safety and efficacy into one, congealing it into one number.
So, so this question is again, people struggle with a lot, and particularly in atrial fibrillation, you know, there's a CHADS-VASc score to try to figure out the stroke risk for patients, and then there's a Has-Bled score, which tries to figure out the bleed risk of the patient. Those two cannot be joined together. You have to kind of make the clinical judgment, you know, to see where your patient would actually fit in. Is the risk of anticoagulating your patient outweigh the benefit, or the benefit outweighs the risk? You know, and I think that will be a clinical judgment, but there isn't one statistic you can put it together with. And the trial I can think of is a Warcef trial, where they used warfarin and compared it with aspirin, you know, versus placebo, try to see if it's better for use in patients with congestive heart failure. And the reason why this was done is that people thought that patients with congestive heart failure should be empirically anticoagulated. And what they found was that there was a small benefit in terms of anticoagulation, in terms of cardiovascular outcomes and stroke prevention, which was overcome by all-cause major bleed. So again, there was number needed to treat for that, but then there was number needed to harm for all-cause major bleed. And ultimately, the authors concluded it was a net neutral trial where they thought that again, the risk and benefits would not warrant all heart failure patients getting anticoagulated, because again, you don't get that net benefit that you're looking for.
Thank you guys both for the wonderful talk. This question is for Munira. Munira, for those of us who are MDs and we see, like, yes, there is value, obviously there's value in translational research. What advice do you have for us if we want to reconnect with PhDs to help participate in these translational research opportunities?
So NIH has a program called Bench to Bedside Research Program, and I serve on that review panel, and they give a ton of money. They give close to $500,000 for 3 years. So the key really is for you to find a collaborator at the NIH. So let's say you're studying breast cancer. If you can find somebody at the NIH who works on breast cancer, then you enter into a collaboration. And one of the requirements for the Bench to Bedside Awards is that you have to have an extramural collaborator, somebody outside of the NIH and somebody in the NIH. And it doesn't have to be NCI, it can be any institute in the NIH. And these awards are not really that hard to get, served on my panel. So, I mean, look up your relevant people that do research at NIH. I will be very happy to connect you with whoever you want to connect. And because, you know, like somebody like me who does very basic research, it's been great for me to collaborate. So we collaborate with breast cancer people. We're collaborating with Anish right now on small cell lung cancer. We have a collaboration on colorectal cancer. And we're really excited that the clinicians are looking at us to like come. So the protein that I studied, see, the thing is that clinicians don't really go and read the basic research. And basic researchers are scrambling, you know, to get a clinical component to get funded for their grants. But it's not very easy so I'm NIH, I'm very fortunate. So the way my lab gets funded is I get funded for every 4 years. I get evaluated by an extramural panel of scientists, international. I'm having one on Monday. So, and that's a tough one. It's sink or swim, 4 years. But I think you guys should really try to reach out for NIH investigators that do very basic research. And if you're a clinician looking for a bench to bedside, I think it's exactly possible. And you don't even really have to write the grant, because in the intramural, we have a lot of resources, a lot. So we can very easily, like if you come up to me and say, I want to sequence, 20 patient tumor samples, I could very easily do it for you, because we have a lot of resources. We get subsidized for a lot of money. Our budget goes every year. So it's possible, but I really, in terms of cancer, I really encourage oncologists such as yourself to look at NIH and what resources. I mean, it's federal taxpayers' dollars. And I think we should all take advantage of it. And that goes at every level, not in, and I can just share one very personal note with you. So when Burhanuddin Mullah came to Washington Masjid, and the Masjid Iftitah happened in Washington, 2004, hamara ghare pehli ziyafat thayli Mullah ne, and Mullah spent about 2.5 hours in my house, and I explained to Mullah a lot about my research. In my bedroom I had plates, because we were doing FDA-approved compounds and all. And when Mullah was leaving my house, he called me and he said, I want to talk to you. And I was very nervous. Mullah was 94 years old. My husband was bringing him down the flight of stairs, and Shehzada Sahab, Idris Bhai Sahab was staying with us. And he said, Babaji Sahab bulave. And then I went, and Mullah said, ke tame mane baddi aras hamna kidi ke tame cancer na causes na upar cure na upar research karo છો. મારી એમ રાય છે કે તમે તમારું આખું રિસર્ચનું રૂખ બદલી લો અને કેન્સરના કોઝિસના ઉપર રિસર્ચ કરો. And then Mullah came down, and then as he was leaving my house, he called me again, and he said કે તમે મને પૂછું ના કે મેં તમને એમ શું કામ કહ્યું કે કોઝિસના ઉપર રિસર્ચ કરો. તો મેં મુલાને, like of course I was shivering, right? And then I told, Ji Mullah. So Mullah looked at me, and then till he sat in my husband's car, and till Mullah left, and Mullah has made this reference to me every time he saw me, even Mufaddal Mullah. Mullah always looks at me and says, તમે કોઝિસના ઉપર રિસર્ચ કરો. જો તમે કોઝિસના ઉપર રિસર્ચ કરશો, આપણે કેન્સર થવા નહીં દઈએ તો આપણે ઇલાજ કરવાની શું જરૂર છે? Like, and honestly, Mullah said this to me in 2004. 2009, the whole world, cancer community, came down to a consensus that we are not going to try to cure. We are going to go to the root cause of cancer, and that is where most of the research effort is. Let's try to find out the cause, because then we can make a customized therapy. And Mufaddal Mullah ni pan em જ રાય છે કે let's get to the root problem of it. So anyway, to answer your question, I'll be happy to help you or anybody else who wants to get connected at the NIH for clinical trials, for training, for opportunities. I just think it's a great federal facility. And like, students can come there for summer, they can come there for internships after their bachelor's for 1 year, 2 years. They can come there to do their fellowships. The stipends are very good. You can come for postdocs. So I would take it as a community service to help the community to accomplish some of the training and career goals. And please, I'm dedicated to this, and I promise to help you.
All right, well, that actually gets us off exactly on time. I want to, on behalf of the board of SBMAH, thank both of our panelists today for the hard work and the effort that they put into this.
Thank you.
Dr. Munira
Thank you.
came in the middle of a grant application.
Thank you.
We appreciate it.
Thank you.
And Dr. Burhan Bhai.